Hello, my name is Toby Rogers. I'm an interventional cardiologist at the MedStar Washington Hospital Center in Washington, D.C., and at the National Heart, Lung, and Blood Institute in Bethesda, Maryland. And I'm going to be speaking today about transcatheter aortic valve replacement in low-risk patients with bicuspid aortic stenosis and presenting the one-year results from the LRT trial. These are my disclosures. So the LRT trial was a prospective multi-center registry in the United States. The primary endpoint was all-cause mortality at 30 days, and we studied a number of secondary endpoints focusing on safety and efficacy, clinical outcomes, hemodynamics, and every patient underwent a CT at 30 days to evaluate for leaflet thrombosis. The patients were enrolled between 2016 and 2020. We presented the 30-day results of the bicuspid cohort this time last year, and the paper was published for all to read online. I'd like to just take a moment to thank everyone who is involved behind the scenes in running this trial and the enrolling sites across the United States. So let's get into the meat of this. The key inclusion-exclusion criteria were fairly typical. These were low-risk patients with a bicuspid valve confirmed by CT, STS prom under 3. All patients had to be suitable for transfemoral access. And the key exclusion criteria were basically there to ensure that these patients were indeed low risk. These are the baseline characteristics, the first column showing the bicuspid TAVR patients. And then just to put it in context, we compare this with a cohort of patients who underwent surgery for their bicuspid valve at the same institutions during the same enrolling period, and a cohort of patients who underwent TAVR for tricuspid aortic stenosis in the other arm of the LRT trial that's been previously published. What you'll notice here is that the patients with bicuspid valve are typically younger than those with tricuspid, and with as one might expect, with a younger population with a lower burden of comorbidities. All patients were classified using the Sievers classification. You can see that the majority of patients in this trial were Sievers type 1, that is patients with a single fused raphe. In terms of the baseline CT analysis, aside from Sievers, we also looked at other things, including the aortic annulus, which, as you can see, was fairly eccentric in this patient population. Coronary heights were normal. And importantly, we excluded patients who had an aortopathy along with their bicuspid valve. So all patients in this study had an ascending aorta that measured under the guideline recommendations. In terms of procedural details, this was a transfemoral TAVR study. Almost every patient had pre-dilatation, which I think is fairly standard, and approximately 2/3 of patients received a balloon expandable valve and 1/3 a self-expanding, and the choice of valve was at the individual operator discretion. The primary endpoint, as presented last year, 0 mortality at 30 days. So I'll move on to the one-year clinical outcome, which is what is new in this presentation. So one patient died between 30 days and 1 year, and that was a sudden death with no post-mortem performed. 4.5% of patients suffered a stroke at 1 year, but none of these were disabling in nature. The pacemaker implantation rate was 13.6% at 1 year, which was almost double that of the tricuspid TAVR cohort, which is certainly something to think about as we consider TAVR in younger patients with bicuspid valve. We got good symptomatic improvements with NYHA class falling as consistent with pretty much every other TAVR study. Hemodynamics were very durable out to 1 year by echocardiography, and no patients at 1 year had greater than mild paravalvular aortic regurgitation. As I mentioned, every patient also underwent a CT scan at 30 days to evaluate for leaflet thrombosis, focusing on hypoattenuating leaflet thickening, reduced leaflet motion, and the combination of the two, hypoattenuation affecting motion. As you can see here, HALT, or hypoattenuated leaflet thickening, was observed in 10.2% of patients, which is very similar to the tricuspid cohort, which was about 14%, and slightly fewer patients had reduced leaflet motion and hypoattenuation affecting motion. So to conclude, low-risk patients with bicuspid aortic stenosis were younger than patients with tricuspid aortic stenosis, but only a minority of them had Sievers type 0 morphology, and the mean age was still in the high 60s. So we have to be very cautious when we extrapolate these findings to even younger patients with severe aortic stenosis and a type 0 morphology. The clinical outcomes on TAVR valve hemodynamics remained excellent at 1 year, and subclinical leaflet thrombosis rate was similar to patients with tricuspid aortic stenosis, but we didn't see any clear correlation with clinical events, And I think larger samples and longer follow-up will be required to determine whether this subclinical phenomena actually has an impact on, for example, valve durability. Thank you.